Hello doctors. Today we are going to discuss the part 2 of chest wall deformity, starting with the pectus carinatum. In my previous video I have already told about the pectus excavatum and the classification. I will give the video of that link in my description. So we will start with the pectus carinatum. Pectus carinatum is forward protrusion of the sternum and the costochondral junction, also known as pigeon's chest. Second most common deformity, chest wall deformity, is pectus carinatum. As we can see this in this diagram, this is the protrusion of the chest wall, which is known as pectus carinatum. Incidence is 1 in 1,500 cases, and it is more common in males, and etiology is still unknown. No one knows the exact etiology. The pathogenesis is there is overgrowth of the ribs which are present here. There is overgrowth of the ribs which causes the pectus carinatum, and this is associated with cardiac anomaly, Noonan syndrome, connective tissue disorder, and cardiac pulmonary symptoms are generally rare, not so common in pectus carinatum. Now we have two types of pectus carinatum. I have also told that in Ectopia classification in my previous video. So we have type 1 pectus carinatum and type 2 pectus carinatum. Type 1 is chondroglandular and type 2 is chondromandibular. So as you know, manubrial. So manubrium is mainly the manubrial part of the sternum is present over the upper portion. We have the manubrium sterni, then the body of the sternum, and then we have the xiphisternum. So manubrium is in the upper part. So type 2 is more common in the upper part. Here also you can see type 2 is more common in the upper part, and the type 1 is more common in the middle and the lower part of the sternum. But type 1 is more common is type 1, type 2 is less common, and type 1 is generally seen in adolescent. When the child grows after 11 years or 10 years, you can see type 1 pectus carinatum. But type 2 pectus carinatum is seen in much younger age, in 5 or 6 year old child. Now this type 2 pectus carinatum is manubrium is protruded forward, so this is mainly known as pouter pigeon. And type 1 pectus carinatum is also known as kneel chest or chicken breast. Now type 2 pectus carinatum have Carinatum-Silverman syndrome, which is important. Carinatum-Silverman syndrome is early fusion and ossification of manubriosternal joint and the sternum. The manubriosternal joint, this joint ossifies early than what is the minimal age, ossifies early than that. Therefore the sternum is short and sternum is thick. Sternum is short and thick. This is known as Carinatum-Silverman syndrome. It is asked many times, so remember that. Now investigation of choice for this pectus carinatum is CT scan of chest, and management is, what is the management? Management is Ravage procedure. I have already told the Ravage procedure in part 1 of chest wall deformity. What is that? That is resection of the costal cartilage, and double osteotomy may be also required. That is correction of the chondromanubrial prominence. Now the chest may be two type of deformity may be there. The deformity is symmetrically present on the both the side of the chest, or this it is asymmetrical. Chest is asymmetrical. If the chest is symmetrical, then we will do transverse osteomy. If there is asymmetrical chest, then we will do oblique osteomy. Now we have the orthotic brace system also. This is the first management, number 1, that is Ravage procedure. Number 2 is orthotic brace system. That is, we will put braces around the chest. We have the chest cavity and we will put braces around the chest. Outside the chest, we will put a brace. We will tell the patient to always have this brace whenever he is walking. But the disadvantage of this orthotic brace is in non-compliance of the patient. Patient doesn't want to wear these braces, especially it is only given in children who are more than 10 years of age, 11 years of age, because younger children will not wear these braces, and minor complication will, by continuous wearing of these braces, will cause ulceration, hematoma and back pain. Therefore there is non-compliance of orthotic brace system. Now we have Abrahamson's intrathoracic compression. We have already seen the NUS procedure. We have seen the NUS procedure in part 1 of chest wall deformity. In NUS procedure, what we'll do, we will generally nickel plates are used in NUS procedure. So here that is reverse Nuss procedure is also known as Abrahamson. Here also intrathoracic compression is given. The metal bar is placed in the presternal space under the pectoralis major muscle, and device is removed after 2 or more years, and then at that time the chest wall comes to a normal position. And apart from that, we have also thoracoscopic cartilage resection. As you know, this is according to Acastello classification. This is type 1 Acastello classification, comes under which we have the pectus excavatum and pectus carinatum, which is an costal deformity. Therefore, if we excise the cartilage, then proper cartilage will grow back and the deformity will reduce. Now we have the second type 2. Type 2 is costal abnormality, means ribs are abnormal. Now we have according to Acastello, costal abnormality is type 2 under type 2, and according to Vital's classification, that is type 10. Now dysmorphic or non-syndromic. We can classify this costal anomaly either dysmorphic or non-syndromic, or we can classify another type, that is syndromic. It is associated with syndromes or it is not associated with syndromes. Type 1, which is not associated syndrome, non-syndromic, is type 1A is numerous ribs are present, and type 1B have bifid ribs, but this is close to the vertebral body. So this is type 1A and this is type 1B. That is type 1A is numerous rib and type 1B is bifid rib but close to the vertebral body, and type 2 also have bifid rib, but this is originating from lateral aspect. The lateral aspect of the chest have bifid rib. In here, this is the vertebra and we have the ribs. The bifid ribs are present near the vertebra. From here, this is bifid, then this is type 1B. If this is vertebra and ribs are originating, after laterally it comes, then the ribs becomes bifid, then this is type 2 costal abnormality. Type 3 is non-bifid rib, depressed thoracic cavity. The thoracic cavity is depressed. That is type 3. Now we have the syndromic costal anomalies. Syndromic costal anomalies, we have the Juane syndrome, cerebro-costal mandibular syndrome, and Charcot-Levin syndrome. We have these three syndromes. Juave syndrome is many times asked. It is an autosomal recessive disorder and severe bone deformity resulting in the thorax will be narrow but it will be long thorax and intrathoracic space is decreased. In these 3 points you have to remember: narrow thorax, long thorax, and intrathoracic space is decreased in Juave syndrome, which is seen in 1 in 30,000 cases. In cases of cerebro-costal mandibular syndrome, which is known as Peary-Robin anomaly. Remember the name, Peary-Robin anomaly, cerebro-costal mandibular syndrome, and this is asked in MCQ once in NEET SS. In cerebro-costal mandibular syndrome, the ribs which are frequently involved are 3rd to 7th ribs. The ribs which are frequently involved are 3rd to 7th rib. Remember this point. And in Charcot-Levin syndrome, we have the spondylocostal dystosis. That is crab-like appearance on chest X-ray. There is crowding of rib. Here we can see the crab-like appearance. There is crab-like appearance in chest X-ray. This is Charcot-Levin syndrome. Okay. Now we have type 3. Type 3 is costochondral anomalies, which is also known as Poland syndrome, which you might have already read in chapter of breast. That is Poland syndrome. Poland syndrome is present in 1 in 30,000 cases, reported first by a scientist named Poland. That's why the name is Poland syndrome. The feature is absence or hypoplasia. There is either absence of pectoralis major muscle or hypoplasia of pectoralis major muscle. With that, there may be absence of ribs. Ipsilateral breast hypoplasia is very common. Along with that, absence of axillary hair over that side. Axillary hairs are also absent. Upper limb anomalies may be present and usually unilateral, and it is more commonly over the right side. This is asked many times. Over the right side it is majorly common. Now etiology. Etiology is unknown and interrupted. Maybe it is because of interrupted blood supply to the vertebral artery and the subclavian artery. I have already told the arterial system of the body. You can go to my arterial system playlist and watch that videos from where which artery comes. So we have the interrupted blood supply of vertebral or subclavian vessels. Because of that, Poland syndrome happens, and this occurs in embryonic period. Intrauterine vascular accident have happened. Because of that, Poland syndrome have happened, and it is also more common in male. it is autosomal dominant. Remember this. This is autosomal dominant. Zuvain syndrome was autosomal recessive, but Poland syndrome is autosomal dominant. It may be sporadic also. It is not always familial. For Poland syndrome may be sporadic also. But if it is familial, it is autosomal dominant. Associated with Moebius syndrome, Sprengel syndrome and Fayol syndrome is associated with the Poland syndrome generally. Its presentation is extremely variable. I have already told pectoralis hypoplasia or absent pectoralis, ribs agenesis or hypoplasia which causes resulting in lung herniation and paradoxical chest movement. And third and fourth ribs are most commonly involved in Poland syndrome. Hypoplasia and total agenesis of mammary gland is also present, and scoliosis or renal anomalies are rarely present. And if it is left-sided, if the Poland syndrome, I have already told Poland syndrome is more common in the right side, but if it is over the left side, then the patient is generally having dextrocardia, means the heart is present over the right side if there is left-sided Poland syndrome. Now, management criteria for repair. When we will repair in cases of Poland syndrome, we don't always repair in cases of Poland syndrome. Where we will repair when there is absent ribs and when there is severe ipsilateral concave deformity is present. Then we take the patient for thoracoplasty. And this is done after the age of adolescence or late adolescence. During the adolescent period, we do the thoracoplasty. That is autologous rib graft. We put ribs if the ribs are absent, and we do latissimus dorsi flap and breast reconstruction. As breast hypoplasia or absent mammary gland is very common in cases of Poland syndrome, we will do breast reconstruction. Either we can give implants. We know the breast implant like silicone implants or saline implants we can use, or we can use omental flap or lipofilling. We can fill fat in that area to look like a breast. That is type 3, that is Poland syndrome. Now type 4, according to Castello classification, that is sternal abnormality. There is abnormality in the sternum. That is rare. This is the most rare cause, that is less than 1%. Superior is more common. Complete paradoxical movement of respiratory distress, and it is associated with 82% of cases. If there is sternal anomaly, then 82% chances that these things will also present in that child. That is, number 1 is hemangioma. Then the child may have cleft lip, cleft palate, gastrochiasis. Cardiac anomalies are very common in sternal anomalies. Then patient will have coarctation of aorta. Then sternal rotation and pentalogy of Cantrell may be present. According to Schamberger and Welch classification, if there is Ectopia cordis, the Ectopia cordis may be classified into type 1, type 2, type 3 and type 4. The type 1 is thoracic Ectopia cordis, means the Ectopia cordis means heart is outside. We can see the heart outside, like here in the diagram we can see this is the heart. We can see the heart outside. This is known as Ectopia cordis. So that can be thoracic Ectopia cordis. This is the thoracic Ectopia cordis, and there may be cervical Ectopia cordis, that is present here. If there is cervical Ectopia cordis or thoracic Ectopia cordis, both of these condition of thoracic and cervical Ectopia cordis, these both are very, very fatal. The child will die in most of the cases. And thoracoabdominal Ectopia cordis may be there, and isolated sternal cleft may be also present. Thoracoabdominal means in this region, in either thoracic or this is thoracoabdominal region, or it may be present in abdomen, which is very rare. Thoracoabdominal is more common. Now, management of this is primary surgical closure is done. If we can put the heart inside and we can close, primary closure can be done in neonatal period. Because the bones are very pliable, so easily closure can be done. But after, even in neonatal age, the closure is done, there will be extensive mobilization of the sternoclavicular joint and disarticulation. Medialization of the neck muscle will be there, and sternal osteotomy is required in primary closure. Then we can use prosthesis if primary closure is not possible. And apart from that, partial thymectomy is also needed maybe, and complication is circulatory compromise, and the child will have infection later on, or early or late infections can happen in this child. So we have covered the thoracic deformity. Next we will continue with the other topics of the pediatric surgery. Thank you for watching this video, guys. Please do like, share and subscribe to this channel so that I can make more free videos for all the medical students. Thank you, guys.